So thank you all for coming. I want to acknowledge funding from NHLBI, and I don't have any other conflicts to disclose. So my research focuses on making sure that patients who need the ICU get into the ICU, and patients who don't need the ICU stay out of the ICU. And this concept really came to me, kind of hit a chord as a resident at Southwestern and as a fellow at Michigan, where oftentimes I'd be the one holding the admissions pages for the ICU. And so I get these pages for patients who people thought needed to go to the ICU. And when I thought about it, there were really kind of three different types, broad categories of pages that I would receive. So the first type of page is actually kind of the easiest type of page, right? Like from a decision making of whether they need the ICU or not. You can kind of turn your brain off from that standpoint, in that this patient is coming to the ICU, right? All you really have to do is go to the charge nurse and tell them you need a bed. And then obviously there's going to be a lot of work after that, but from whether they need the ICU or not, there's very little thought process involved. The second type of patient is a bit more annoying, maybe a little amusing, right? Like you get this page and you're just kind of frantically like flipping through the chart, trying to figure out like what you're missing about this patient. Like, why are they paging the ICU fellow for this? Like, it doesn't make any sense. And, you know, invariably, they meant to call the pulmonary consult fellow or something like that, right? Like, this is a patient who, no matter what hospital you're at, there's really no reason for someone like this to come to the ICU. And then there's this third type. There's this third type of patient who really kept me up at night, still keeps me up at night. I'm not sure whether they should come to the ICU or not. They might benefit, they might not, and I really am not sure. So here we have kind of a 93-year-old woman. She's got a PE. She's got kind of a borderline blood pressure. Her oxygenation is kind of borderline on 6 liters of oxygen. You know, there's nothing specifically in the ICU that we're going to provide this patient, right? They're not going to be on mechanical ventilation right now. They're not going to be on pressors. So from a traditional standpoint, what are we actually offering for this patient in the ICU? But at the same time, you could argue that being in a place where they have 1-to-1 or 1-to-2 nursing, someone there just like watching this patient because they may not have a lot of reserve, might be helpful for this patient compared to being on the floor, having a nurse check on them, you know, every, you know, hour, 2 hours. Being in the ICU might be meaningful for this patient, might help them a lot. And so one of the things that I like to do is get a sense as to like what your guys' practice is. So I've had some fascinating discussions last night at dinner and with the fellows and the applicants today about kind of their experiences. But what I'd like to do is kind of run through 3 different cases and just get a sense as to whether you would admit this patient to the ICU or to the regular floor. And these are cases that are taken straight from the University of Michigan. So after I get a sense of what you guys would do, I'll say what actually happened to this patient. So for this first case, we have a 58-year-old male. He's got no past medical history. He's got pneumonia. He's hypoxic. He's got altered mental status. In the ED, he gets intubated. He's got copious secretions. So kind of a show of hands, who would admit this patient to the ICU? Yeah, and anybody who would not admit this patient to the ICU? Yeah, so this is kind of a softball, right? Pretty much any hospital that you're at, this patient would get admitted to the ICU. All right, so the second case, again, also a patient from the University of Michigan. So we have a 38-year-old female. She's got metastatic breast cancer. She comes in with pneumonia. She's on 50% face mask. She has chosen to be DNR, DNI. Would you admit this patient to the ICU? Hands for anybody who would admit this patient to the ICU? Okay. We have one person who would admit this patient to the ICU. Hands for who would admit this patient to the floor? Okay. The majority of people, it seems like, would admit this patient to the floor. And at the University of Michigan, this is a patient who was admitted to the floor. Now, I will say, I took care of a very similar patient in residency. And I can still remember this patient, mainly because I remember it was my co-resident taking care of the patient, and he said, I really would like to get this patient to the ICU. You know, even though she's DNR or DNI, I think we can take better care of her in the ICU. And she may get better and she may not, but at least it would give her time to make decisions about her life. And I remember that patient very vividly. And we didn't bring that patient to the ICU, but I still kind of wonder if things could have been different if we did. Okay, so here's the third case. So you have a 50-year-old female. She's got COPD. She comes in with pneumonia. She's on 2 liters of oxygen at baseline. Now she's on 6 liters. She's has an oxygen saturation of 90%, and she's altered. So how many people here would admit this patient to the ICU? Okay, how many people would admit this patient to the floor? Okay, so the majority would admit this patient to the ICU. Some would admit this patient to the floor. In all honesty, from the discussions that I have heard about Monty, it seems like this is a patient that would typically go to the floor. Maybe not, like 6 liters.
Not exactly. I mean, that sounds like a patient that can get a trial of therapy for a little bit before you make a final decision on whether the patient comes to the ICU. If the patient gets better, then they're okay for the floor. If the patient is teetering or not getting better, I would admit to the ICU or step down.
Okay. Yeah.
I mean, the thing that's pushing me over is the altered, and it kind of depends on how altered the patient is. And then if you're talking about like a trial of therapy, I don't really know what that therapy is. I don't know what therapy for this patient is going to get them better to the point that they're really able to. Right? If they got pneumonia, they get an antibiotic, that's not going to change things in there.
Right. It's different from like a COPD exacerbation. You put them on BiPAP for a couple hours, see if they turn around, essentially. Pneumonia takes a little bit longer to resolve and get better. Yeah, so there are various kind of variables involved. So so I presented a case just like this to 400 physicians around the country. So this exact same case. And this is what we found, right? So kind of 2 things to take from this figure. One, clearly there's no agreement among physicians. Right? These are intensivists. But second, essentially the same proportion of physicians who strongly believe this patient would benefit from the general ward strongly believe that they would benefit from the ICU. So clearly, we as intensivists don't agree about what types of patients actually benefit from being in the ICU. And why does that matter? Well, the only source of guidance that we have is ICU admission and triage recommendations guidelines from the Society of Critical Care Medicine. And their advice is that patients be admitted to the ICU based solely on their potential to benefit. And if we as intensivists can't agree about whether a patient would benefit or not from the ICU, then operationalizing this statement is impossible. So this concept of benefit from the ICU is incredibly important, but difficult to gauge. And what does this translate to in clinical practice? Well, it translates to this. There's tons of variation in how we use the ICU across the country in the US. There are some hospitals that admit as much as half of their patients to the ICU. And there are other hospitals who admit as few as 3% of similar patients to the ICU. So there's tremendous variation across hospitals in how we use the ICU. And so there's no question, I think you'd be hard pressed to find anyone who believes that we in the US don't overuse the ICU in general. That's been shown previously by Haley Gershengorn with diabetic ketoacidosis. Here I show work by my colleagues Andy Admin and Colin Cook with pulmonary embolism. So on the y-axis here we have mortality rate, and on the x-axis we have ICU admission rate. And we see that there's essentially no relationship between how sick a patient is and whether they actually go to the ICU. And so in general, it seems like we probably overuse the ICU for these kind of low acuity conditions, where ICU care probably doesn't really give you a lot of bang for your buck in these conditions. And from this work, we also know that if you go to the ICU, you're also more likely to get a lot of these procedures, like central lines and A lines, that you may or may not actually need, particularly for conditions at a fairly low mortality rate. So from a personal standpoint, at a patient level, ICU overuse may or may not hurt the individual. You may get more procedures, but it's still kind of gray as to, at a patient individual level, is ICU overuse harmful? But certainly at a societal level, ICU overuse is harmful. Right? In this figure, taken from large-scale administrative data, this first column on your left shows stays, discharges in the U.S., and we see that about a quarter of all hospital stays involve the ICU, and that from that quarter, that leads to about half of all hospital charges. Right? So a quarter of all hospital stays results in half of hospital charges. So ICU care is tremendously expensive. And so if we don't need the ICU, that overuse is affecting our society. But is ICU underuse actually a thing, particularly in the US? Right? So in this paper from Hannah Wunsch, she looked at kind of practices of ICU use across different countries. And we see the US way over there as an outlier, right? We have about 6 million ICU admissions per year, and we have way more ICU beds than these other countries. So I think generally people believe we tend to overuse the ICU in the US, but are there ever situations where we actually underuse the ICU? So let me illustrate a possibility of a population of patients where we may actually underuse or overuse the ICU. And I'll illustrate that with this example. So let's take two hospitals. This first hospital, Hospital A, uses the ICU a lot. So they have a lower threshold for ICU admission. It's easier to get into their ICU. Right? It doesn't take a whole lot. The second hospital, Hospital B, let's call it, I don't know, Monty, has a higher threshold for ICU admission. It's hard to get into their ICU, right? So if you show up at Hospital A, you're probably more likely to be admitted to the ICU than at Hospital B. Now, both of these hospitals, there are two groups of patients, right? There are patients who would always get admitted to the ICU. And this is a slide that I generally use, but apparently like on vent and presses is not good enough here. We'll say like escalating vent and pressor requirements will get you into the ICU here, you know, and with a good prognosis, yeah. But, you know, there's a population of patients who would get admitted to the ICU regardless of where they are. Right? And then there's also a population of patients who would never get admitted to the ICU regardless of where they are. Say, you know, a patient with pneumonia, they can't tolerate oral antibiotics, so they need some IV antibiotics, right? You'd be hard-pressed to find any hospital, even community hospitals, that would admit such a patient to the ICU. But there's also this particular group of patients who only get admitted to the ICU depending on which hospital they happen to show up at, right? If this hospital happened to show up at Hospital A that uses the ICU a lot, they get admitted to the ICU. If they happen to show up at Hospital B that doesn't use the ICU a lot, they don't get admitted to the ICU. Right? So this is a patient population where there to some extent is clinical equipoise, right? Reasonable clinicians might disagree about whether or not they should go to the ICU. And so what we did was we looked at this specific population of patients using a statistical technique called an instrumental variable analysis. And we looked at what are the outcomes for these patients, right? These patients who we as clinicians have trouble gauging whether or not they should go to the ICU or not. And what we found in two conditions, in pneumonia and in STEMI, was that there was a dramatic reduction in 30-day mortality associated with ICU admission for this population. So for this population, if they were admitted to the ICU, they had a 6 percentage point reduction in 30-day mortality. Right? And so this is a population of patients who theoretically are not on mechanical ventilation, are not on life support or vasopressors, right? And they're also patients who are otherwise well and wouldn't really need the ICU in general. Right? So this is kind of our sweet spot of people who could kind of go either way. And ICU, and again, this is also in Medicare data, so they tend to be older. So when we looked at this a bit more closely, this when we broadly characterize this population, this tends to be kind of older patients, right? So like older than the age of 85, people who we may or may not question their long-term prognosis. This tends to be people with fewer organ failures, people who might slip through the cracks. They don't look that obviously ill, and they benefited from the ICU. So it's not necessarily, what I like to say is it's not necessarily that we systematically overuse the ICU or that we systematically underuse the ICU, but what we do is systematically misuse the ICU, right? We don't know who should go to the ICU, and as a result, we pick and choose and we may not be right? So we need better ways of figuring out who would actually benefit. Because like any therapy, and particularly any costly therapy, we can't just apply this care indiscriminately. Right? We need to be able to know which patients benefit and which ones don't. And so in that way, it's no different from any other drug trial, right? We wouldn't just give the newest drug to everybody. We would target it to the people who we think would benefit. But we've never actually done that for ICU. Right? We just apply it indiscriminately. And so that's what my K revolves around. Essentially this question of, can we improve the way that we use the ICU? And there are three parts to my K. The first is what we as clinicians actually care about, which is to, the question I get, which is like, what do I do? Like, help me identify those patients who should go to the ICU. So that's the first part. Can we actually identify who these high benefit patients are? The second is to understand what about physicians drives our thinking. Like how do we think about these patients, and how do we decide which patients go to the ICU and which ones don't? Because it's one thing to have a risk model, but it's another thing to actually implement it in a situation where a clinician believes that a certain patient should go to the ICU and another patient shouldn't. And then the third is to recognize that there are other things that affect these decisions that are non-clinical, that are unrelated to the patient, right? What are the hospital level factors? What are the organizational factors that I've heard quite a bit affect your guys' thinking, but that certainly affect everyone universally? So I want to take a step back and kind of ask you guys, what are some of these things at a hospital level, structural level, that influence whether or not a patient, your patient, goes to the ICU? Bed availability? Yeah. So okay. So whether or not ICU beds are available? Okay, good. What other things influence, unrelated to the patient? Doesn't matter what's going on with the patient, but like they influence whether or not someone's going to go to the ICU. Okay. Yeah, so code status is more of a patient level variable, but certainly how a hospital deals with code status. So maybe the culture of the hospital. Some hospitals might treat DNR, DNI beyond what it actually means, right? There's some work that shows, DNR, DNI means that you don't want to get resuscitated in the event of a cardiac arrest, and you don't want to get intubated in a respiratory arrest, but it doesn't actually mean anything related to whether or not you should go to the ICU, right? So that's the institutional practice or culture that you're extending what it actually means to something else, right? What else?
Availability of services.
Okay, availability of services. Anything in particular you're thinking of?
Well, for example, endoscopy.
Okay, maybe on the weekends, you might not be able to use the endoscopy suite, and so someone needs to come to the ICU on the weekends. We experience that at the University of Michigan regularly. Like someone has a GI bleed, the medical procedures unit is closed on the weekend, so you need to bring them to the ICU on the weekend.
It's good to know it's not just us.
Michelle, you had something?
Yeah, what is possible to do on the floor?
Yeah, so a big question is what can the floor handle, and whether we can handle that on the floor, or whether they need to come to ICU as an escalation of care. Yeah, so what we know in the literature about these things are ICU bed availability. That's probably the most well documented. There's a whole wealth of literature that says if there are fewer ICU beds, patients are less likely to move to the ICU. And there's some more recent work out of Penn from George Anisi that looked at kind of a curve of like at what point do you start to get stingy with your bed. And definitely like it plateaus at 5. So if you have 5 or more ICU beds, it's basically kind of like doesn't matter. Your bed availability doesn't matter. But as you decrease from 5, you start to get stingier and stingier about who gets to go to the ICU or not. So bed availability is a clear organizational factor. Protocols matter. Whether DNR, that's a little bit fuzzier than a protocol. I'd say that's more of a culture or a practice. But like CKA, there are some hospitals where IV insulin can only be given in an ICU. And so that protocol matters very much, right? Your hands are essentially tied if someone needs IV insulin. Census matters, right? If your ICU census or even your floor census or your ED census affects how you use the ICU. And then intermediate care. We don't know a whole lot about intermediate care, but generally we know that if it's there, it tends to be used, right? And so there are certainly hospitals that use intermediate care is either to help the outflow of the ICU or to potentially as a resource to take some of those lower acuity ICU patients, maybe some of those borderline patients, and admit them there instead of the ICU. Absolutely.
4 hours.
Yeah. So there is not a lot of literature on critical care consult services. I want to say the Penn group might have a paper on it, because I think they also have a critical care group, but it's not widely, like, I'll get to kind of the study that we've been doing, but like of 8 hospitals in Michigan, no one really has a similar program to what we have. So it's fairly unique, but certainly I would say it might fit under like the protocols or the culture of a hospital, right? And it's almost in some ways a workaround to your resources, right? And I'll get back to that too, right? Like hospitals develop these practices as a workaround for the things that their resources provide to them, right? The structure leads to practices, culture, consult teams, things like that. So all of what we know here is either from single center studies or the use of administrative databases, right? Whether it's Medicare, whether it's other national databases, or whether it's kind of older databases like Project Impact. But we've never really had a larger, multi-center, deeper dive into what are the organizational factors that influence ICU admission. So that's what I'd like to talk to you about for the rest of this talk, which is the study that we're in the middle of doing. So what I'll actually be presenting to you is some preliminary data from that. And what we've devised is essentially as we're going to 8 hospitals around the state of Michigan, and we selected these hospitals based on specific characteristics, whether they're urban or rural, whether they're academic or community, how many ICU beds they have, and generally kind of what their average ICU admission rate is. So we wanted to select kind of a diverse group of hospitals, both geographically and based on these characteristics. And what we're really interested in is what about the hospital influences individual physicians when they make these ICU admission decisions. And what we're doing is we're interviewing hospitalists, ED physicians, intensivists, basically anyone who's intimately involved with that triage decision. We're interviewing them, and we're also interviewing kind of key informants, charge nurses. We go to each hospital, we ask them, who else should we talk to here who's involved in this triage process? So that's included charge nurses. At one hospital included the VP of nursing who's very involved. At another hospital, bed placement. So there are these various informants who are kind of involved in the decision making. We also conduct surveys both with the participants, but also kind of more detailed hospital surveys to understand a bit more about the hospital, things that we don't get out of kind of broad American Hospital Association surveys. And then we're doing site visits. So we're going to each of the 8 hospitals, and we're touring generally the ED, the ICU, and the hospital, and kind of a representative general floor to get a sense of the structure and how that structure, what it looks like, and get a deep feel for the hospital. And so far, we've gone to 4 of these hospitals. And so we've done 4 hospital surveys, we've done 4 site visits, and we have roughly 36 interviews from these hospitals. And I'll go over kind of some of the data that we've gotten and some of the preliminary data that we have. So we can see here of the 4 hospitals, they are a mix of rural and urban, mix of community and academic. They have a range of ICU beds going from 8 to 68. They have a range of hospital beds and a range of ICU admission rates. Their admitting and staffing models differ. So 2 are open, 2 are closed units. The open units are both staffed by hospitalists, and the closed units are both staffed by intensivists. The hospitals C and D are kind of the academic centers. They have residents and fellows. And then there's a range of intermediate care beds, ranging from one hospital that has no intermediate care beds to another that has 74. So the first thing that we'll discuss is just our observations from the site visit. So one of the things that we took away when we visited one hospital in particular was the interchangeability, the flexibility of intermediate versus ICU care. So we visited this hospital, and I'll just kind of paint a picture of it. So it's their unit is a 30-bed unit. In the center, they have this nursing station, and they have 8 contiguous beds that are their ICU beds. And then they have 22 other beds. So they have 8, at maximum, they can have 8 ICU beds. But at any given time, let's say they only have 4 ICU patients, they could have 26 intermediate care patients, right? So they have some flexibility there that can change based generally on the discretion of the charge nurse. So if it's if they have 8 ICU beds, then max they can have 22 intermediate patients, or they could have no ICU patients and 30 intermediate patients. So they have some flexibility there that might influence whether a patient's in ICU care or not. The beds are structurally the same. The ICU beds are, the ICU rooms are a little bit bigger, but everything else monitor-wise is the same. And it's the same physicians that care for everybody in that 30-bed unit. The only thing that changes whether a patient's intermediate or ICU is the nurse staffing. They might go from 1 to 1, 1 to 2 to like 1 to 3, 1 to 4. The second interesting thing that we saw when we came for these site visits was the location where patients were placed. So take this last hospital that I mentioned. If there was a patient who was kind of borderline, they have 8 specific ICU beds. So if a patient's kind of borderline and the nurse isn't sure whether this is really an intermediate or an ICU patient, even if they're listed as an ICU patient or they're listed as an intermediate care patient, if they're kind of on the fence, the charge nurse, he or she, will selectively place a patient in that bed into an ICU bed that could potentially be an intermediate care bed, even if they're in an intermediate care patient. Because if that patient were to get sick, all they have to really do is just flip a switch and now it's an ICU patient. Otherwise, if they were in one of the other beds, they would have to physically move this patient over into an ICU bed. Right? So it alleviated some of the stress on the nursing from that standpoint. And that was entirely up to the discretion of the nursing. The other hospitals were kind of shaped in a U shape, and they have this central kind of fishbowl. And so they would frequently put their sickest patients right in the middle of that fishbowl so that all the eyes could be placed on those sickest patients, and try to avoid having those sick patients on the edge where they might be less likely to have eyes on them. So they took that into account when they made their decisions about triage. And then the final thing that we noticed on the site visits was just where conversations about triage occurred. So in some hospitals, the physicians kind of hang out in that same fishbowl. In some hospitals, they have a separate office, like a floor away, up the stairs, 10 minutes away. And so their proximity to the nurses matters, but also their proximity to the ED, and whether they came down to the ED to actually see patients, whether they talked by phone or by text page, you could see that that matters quite a bit, right, in terms of the workflow of how they triage patients. That's kind of what we've learned so far from the site visit. Now, from the interviews, we'll kind of discuss 4 main themes, and I'll illustrate that going through kind of the 4 different hospitals and an example we've taken from each one of those. So the first is this question of what does ICU triage actually mean? So as intensivists, as academic intensivists, I've always thought of triage as essentially meaning, should this patient go to the floor or should this patient go to the ICU? I'll take this example from one of the small rural hospitals that we visited. So let me, for each hospital that we went to, we also made this kind of diagram of what is their ICU triage process. And we showed it to each person that we interviewed and asked them to kind of give feedback, make changes, so that we could get a rough sense of and deeply understand how triage occurs at the hospital. So this is from one of the small rural hospitals. At the top, you'll see ways that people can get into the ICU. So they either come in through the ED or from the med-surg floors, or very rarely they get transferred from an outside hospital, right? This is a smaller rural hospital. Sometimes there were even smaller rural hospitals that would send patients there. That was pretty rare. So they have patients coming into their ICU from the ED or from the med-surg floor. But what they kept talking about was that to them, the reason why they wanted their intensivists to go down to the ED and see patients wasn't to figure out whether the patient should go to the floor or to the ICU, because invariably, if they were being asked, this patient would come to an ICU. No, the reason why they wanted patients, their physicians, to go down and see the patient in the ED was to figure out whether the patient should stay in that hospital or be referred to another hospital. So to them, their ICU triage question was not, is this patient safe for the floor? It's, is this patient safe for our hospital? And they felt, and there was some disagreement here that we got between the ICU physicians and the ED physicians, that the ED is better at transferring patients, right? That it's easier to send an ED to ED transfer than to bring someone up to the ICU and then find an accepting physician who will take this patient in a timely manner to another hospital. So they felt strongly that if they felt like they couldn't handle this patient, they didn't have the capabilities for this patient, that they should figure that out early and do an ED to ED transfer because it's easier. And because the process is, that track is a bit more well-formed than an ICU to ICU transfer. So to them, triage meant, do we keep them or do we ship them? The second example I wanted to talk about was how triage conversations occur. So this is one of our larger urban hospitals that we visited. And we see at the top that the 3 ways into the ICU tend to be through the emergency department, through the med-surg unit, or from the outside hospitals. Outside hospitals didn't contribute a whole lot into their ICU admissions, but it was more of a presence than the last hospital. But the interesting thing about the way they did things was that they had kind of a one-stop triage conversation. So what they did was, if the patient's in the ED and the ED attending or the ED resident thinks the patient needs to come to the ICU, they call what they call ED1 call, or it's basically kind of a bed manager, the nurse who's the bed manager. And then that nurse then identifies who the intensivist is, and maybe the ICU resident, and gets them onto a conference call. And so then the ED attending and the ICU team talk about the patient. And then if the patient needs to come to, if it's pretty straightforward and the patient comes to the ICU, they have the bed manager there on the phone. If they decide, okay, I'm going to come down and see the patient, then they've made that plan. And then they come down and see the patient and make a decision from that standpoint. So this allowed the ED, the intensivist, and bed management to all be there, rather than kind of have these piecemeal discussions. And similarly, when outside hospital patients want to come in, or whether it's a med-surg patient even, they use the same system. So a hospitalist would call ED1 call, ED1 call would then call the intensivist, and they'd all talk about whether or not the patient should come in, or kind of what steps they were going to take. We talked a bit about this flexibility of this ICU intermediate care. So this is another of the rural hospitals. Their patients come in from the ED or the med-surg unit. Sometimes they had some surgical MDs who admit to their medical ICU, but that was kind of a more rare instance. And they just generally admit to this unit called what they call the TU, the telemetry unit, which functioned as their intermediate care unit. And it's contiguous with their ICU. So they would oftentimes, physicians would just admit patients there, and then like the nurses would sort out whether this patient is ICU or in intermediate status, and then the physician would kind of change the order based on that. But it really didn't affect the physician workflow in any way. It was really more of a nursing question. And then finally, I think something that's come up talking to some of you guys was the another of the large urban hospitals that we went to. And they talked a lot about ED to ICU delays and the workarounds they've created because of those delays. So they had a lot of different ways into their ICU. So you have the traditional ED way in, the traditional kind of med-surg way in. But this was a health system that this health system had a bunch of standalone emergency departments. So basically just like emergency departments without a hospital. And so if a patient showed up there and that ED physician felt like that patient needed to go to the ICU, they would admit them directly into an ICU. So not coming through the ED at this hospital, but would go straight from this standalone ED into their ICU. And then this hospital placed a large priority on transfers from outside hospitals. And oftentimes they would take direct ED transfers straight into their ICU to facilitate that process, but also they'd have other ICUs just admit directly into their ICU. And what the ED found, what the ED found was that they often felt slighted. They felt like they were the lowest priority in admission, right? If someone on the floor got sick, they went quickly to an ICU. And then you had these standalone EDs and these outside hospitals that were taking up these ICU beds. And the ED felt like they were holding on to their patients for long periods of time, hours to days. Right? And so they felt that that hampered their ability to provide good critical care and hampered their ability to provide care for other patients. So what they devised is something similar to actually what you guys did, was basically an ED critical care service, consult service, which if a patient was in the ED for longer than 4 hours, they would consult on and basically kind of take over critical care of those patients. So they take over vent care, they take over kind of fluid monitoring, hemodynamics, a lot of the things that we as intensivists think that patients in the ED might suffer from if they stay there for a long time, right? A lot of those, start them on 100% FiO2, and then you just kind of leave them there, right? Because the ED is taking care of other things, right? So what they did as a workaround was essentially create this critical care consult service to try to fix that problem. And I think similarly, it sounds like you guys essentially created critical care consult service to fix a problem of not having enough ICU beds, right? And having a lot of critically ill patients on the floor. So generally, the question was like, the question we had was, what makes going to the ICU easier? What makes that process easier? Like, that speeds it up, that makes it seem like, okay, we can just get this patient to the ICU, right? And clearly, bed availability matters, right? If you have the ICU beds available, you're much more likely to admit a patient to the ICU. That's quite clear. But there were other things that haven't really been discussed a lot, mainly because they're tough to measure, right? And it's tough to get them from like administrative data, things like that. So one was the prominence of nursing in triage decisions, whether it's physicians talking directly with their charge nurses about what kinds of things the nurses can handle either in their ICU or on the floor, or whether it's nursing making these decisions about whether patients intermediate or ICU level care. So the level of the role that nurses play in these triage decisions varied. The second was kind of how well you know the person who's asking for an ICU bed. We talked about this a little bit, right? About like, I remember as a fellow, if I had a resident paging me who I knew and who I felt was kind of like a strong resident, there wasn't a lot of thought process involved. I usually was like, okay, if you think they need the ICU, they probably need the ICU. Right? And there's very little kind of back and forth pushing, right? Whereas if it's someone who I don't know well, I might go in a little bit more skeptical and say, hey, well, have you done this, this, and this? And if you haven't, well, do those things and call me back, right? So how well you know the ICU physician kind of matters, and that came up a lot in our interviews. One hospital in particular, this was a rural hospital, talked about how they went through a period of time a couple years back where they had a lot of locum physicians, a lot of locum hospitals, and how difficult that was for them as ED physicians trying to make relationships with those physicians, but also kind of convince them of what we can and can't do with this hospital. And so that certainly impacted their ability to perform triage. And they've said that now that they have kind of a permanent hospitalist group, it's made it a lot easier. Right? These hospitals know what should stay, what should go, and what the floor can handle and can't handle. And then along those lines, having for these hospitals that refer a lot of their patients out, or even for academic centers or referral centers that are bringing in a lot of patients, having these kind of pre-existing relationships, these tracks matter a lot, right? Like for that hospital that I mentioned where they feel like it's easier to go for an ED to ED transfer than an ICU to ICU transfer, that might change if they had kind of a well-worn track of, well, if you admit them to the ICU and they're not doing well, just call us and we'll take them, kind of thing, right? And that hospital has just recently joined a larger health system, partly in the hopes that they will have these more developed relationships. So these are some of the things that made getting a patient into the ICU easier. And strictly non-clinical factors, right? There are obviously like clinical factors that make it easy to get a patient into the ICU, right? You intubate someone, more than likely, at most hospitals, they would be going to the ICU, right? you put an A-line in someone, right, and convince someone that they need an A-line, a lot of places they'd be going to the ICU. But then these are some of the organizational or hospital factors that influence that. So what are some of the things that made it more difficult to admit a patient to the ICU? So we talked about beds that could make it easier or harder. But one of the things that we found interesting was that nurse staffing mattered, particularly at these rural hospitals. They actually didn't have a lack of ICU bed availability. Their beds were rarely full. But what happened a lot of times was they didn't have the critical care nursing to adequately staff these beds. So they might have 8 open beds, but they only had staffing for 4. And so they'd have to close down 4 ICU beds because they didn't have enough ICU nurses. Right? Those are things never actually gotten from the administrative data, right? It's all about ICU beds. But it seems like at these rural hospitals, it may be other factors, like nurse staffing, maybe intensivist staffing, but it seems like nurse staffing that affects this kind of bed availability question. The second thing, also something that can't really be measured quite that well, is basically like nursing capability. Right? A lot of these hospitals, the question that came up is this patient safe for the floor? And particularly, can our nurses on the floor handle this patient? And at some of those smaller rural hospitals, it was even in the ICU. It was, can our nurses in the ICU handle this patient? And that can change. So one rural hospital talked about how they had a group of nurses who practiced there for like 30 years. And they all retired at around the same time. And now they have a bunch of fresh nursing grads who are there working. And those nurses are less used to taking care of critically ill, really sick patients. And so what they found is that they're referring out a lot more patients now because their nurse staffing changed. And some of those veteran nurses are gone, and these fresh nurses are just less equipped to take care of these sick patients. And then there's this question of how a patient actually gets to a bed. I remember as a fellow, like the bane of my existence was if our ICU was full, I would have to go down to each ICU and try to barter for a bed, essentially, right? So like our ICU is full, so let me go down to the SICU, let me go find the charge nurse in the SICU, let me find the SICU fellow. Do they have a bed? Can we get one, please? No, okay, let me go up to the CCU now, and that's what we had to do, right? It would have been a lot easier if I could just like ask a bed manager, can you give me an ICU bed, right? Like that's all that we really need. But there were places that kind of talked about that, right? Like they didn't really understand how a bed got assigned. So one ICU told us about they're a medical ICU, but they're kind of like considered like the redheaded stepchild of their hospital compared to the SICU. And so they'd have open ICU beds. They have the nurses ready to take care of patients, and there'd be a critically ill medical patient in the ED or on the floor. And the physicians have decided this patient should come to the ICU, but for some reason, the patient shows up in the SICU. And they have the charge nurse in the ICU has no idea how that even happened. But as a result, she ends up having to float out her nurses because patients who should be coming to a medical ICU aren't because they're, for some reason, lower on the totem pole. So how beds are assigned and the priority that units are placed in is a barrier to how these ICUs are triaged. So to summarize, the things that we found so far. First, triage has different meanings than what I'd initially thought about, right? To me, as an academic intensivist, I'd always thought of triage as being, is this patient safe for the floor? But in many hospitals, that question is rather, is this patient safe for our hospital? And then also, there's a lot of variation in triage that's based on these local capabilities, local practices, local culture that are poorly measured in the ways that we're currently measuring, right? Like based on, and many of these capabilities are perceived, right? Like these nurses don't believe they can care for these patients. And sometimes the physicians try to coach them into saying, we can handle this, we can do this. And sometimes there's pushback, sometimes there's not, right? And so many of these staffing capabilities are perceived. There are certainly technological capabilities that come into play, right? Like a hospital can't do CRT or a hospital can't do ECMO. Certainly that affects things. But a lot of these staffing capabilities are often kind of perceived about whether or not they can handle a given patient. So what does this mean, right? So I think first, hospitals make their triage structure based on the resources that are available to them and just how they've dealt with it, right? That's what's happened, I think, here, is that you have a lot of critically ill patients on the floor. You've created a critical care triage consult service. Similarly, a hospital that has their patients hang out in the ED a lot, like at the University of Michigan. At the University of Michigan, we created an ICU in the ED, basically. And now patients go into this ICU in our emergency department for somewhere between 4 and 24 hours, and basically like hang out there and get critical care, and then come to our ICU because they felt like patients were hanging out in our ICU for too long, or hanging out in our ED for too long, who were critically ill, and that they were suffering for it. So hospitals create these triage models based on the resources that they have. So if we're going to institute new triage models, we have to keep that in mind and tailor them to the hospital and the resources. If you just go into a hospital and say, you know, all STEMI patients need to go to the ICU, or like you need to admit more STEMI patients to the ICU, well, you need to figure out which other patients aren't going to be going to the ICU. Second, there are specific practices that could potentially be bundled together. It's almost kind of best triage practices, right? So this kind of flex ICU, lower acuity bedding model, right? That seems like an ideal way to be able to transition patients who don't need ICU into other levels of care and potentially prevent them from getting some of those procedures that you only do if you're in an ICU. To potentially standardize communication practices, right? Some of the hospitals talk a lot about barriers in communication between triage physicians, ED and ICU. So being able to standardize those practices, reduce some of those barriers related to bed management, things like that. And then having perhaps flex critical care nursing, right? I talked about like a lot of the questions are less about ICU and more about the floor, right? Is this patient safe for the floor? So one way to reduce ICU use is actually to make the floor safer, right? So if the nurses on the floor can't handle something, maybe there's a critical care nurse that can come in, almost like your critical care consult team that's physician run, but maybe there's a critical care nurse involved too, who can be there for, you know, for some level of time to help offload the floor nursing. And then finally, I think something that's kind of under-recognized, you know, there's this question about this looming intensivist shortage in the US, right? And some people feel like it's a myth, some people feel like it's real, but there's certainly a question about whether ICU telemedicine might be a solution for that, right? Particularly in rural hospitals, that maybe ICU telemedicine can reduce this looming intensivist shortage. But what that doesn't necessarily recognize is the potential for critical care nursing shortage, right? That if you don't have ICU nurses at these rural hospitals, there's very little that you can do from a telemedicine standpoint. And so if rural hospitals are having difficulty recruiting and retaining their critical care nurses, that's a big problem, and will greatly affect our ability to provide critical care in rural hospitals. So what does this mean moving forward? So obviously, we still need to complete our site visits and interviews at all 8 hospitals and fully analyze the data. But what I'd like to do is then develop these kind of triage models to test and see what outcomes are actually associated with these models. Right now, we can't actually say which of these models is good and which model is bad. All we're getting is basically a description of what these triage models are, because we don't have that right now. And then potentially figure out which of these models we can actually test against each other and see which might work across